Assemblywoman Rodneyse Bichotte.
Okay. Thank you, Madam Chair. Thank you, Dr. Zucker, for being here. I just want to thank you for all the work that you've been doing and also being a very responsive commissioner. I have a lot of questions, but I will defer some of my questions to my colleague in Brooklyn on the issue of downstate. For now, I wanted to talk a little bit about my concern around the provisions allowing independent practice of nurses administering anesthesia without any supervision. And as I read it, the proposal will create a two-tier care system in my community where the quality of anesthesia care will be determined by a patient's insurance and other economic considerations. Now, you're an anesthesiologist, and I would not think that you would be pushing this type of practice. Shouldn't patients, regardless of types of insurance coverage or income, be provided the highest standard of anesthesia services by physicians that we have in the current state health code? Also, let me just read this. In the provision that you have, it says that nurse anesthesia must be provided in collaboration with a qualified licensed physician. Listen to the key word, in collaboration. And that would mean the administration of anesthesia, anesthesia-related care to patients, pre-anesthesia evaluation, preparation, anesthesia induction, maintenance and emergence, post-anesthesia care, peri-anesthesia nursing, and clinical support functions and pain management. I mean, I would think that you would want the person performing the anesthesia to have sufficient scientific, clinical expertise around that issue, as it's a very, very, very specialized area. And please don't get me wrong, I am full support of nurses getting more training and adding more functions to their workload, but under the supervision of a licensed physician for particular areas. I also want to make note that in the definition of collaborative, it means that means that the certified registered nurse anesthetist shall communicate, whether a person by telephone or through written electronic means, with a licensed physician qualified to determine the need of the service. So to me, what does that mean? I mean, if I'm on the bed, hospital table, and I'm about to be operated on, does that mean that the CNRAs make a phone call or a text a physician and they collaborate on the service right before I go to, into operation? So I do have a concern, and let me tell you, I'm gonna just share a story, a personal experience. I was pregnant a year and a half ago when I was 43, and at 5.5 months, I was at risk of losing my child, which I eventually did. And when I went to Columbia Presbyterian, which was a hospital that completely neglected me and sent me my way, a community hospital in my neighborhood, Wyckoff, picked me up and treated me. And I tell you, right there and then, when I was experiencing excruciating pain, I thought I was gonna die. I told my family I'm gonna die, because that's how I felt. And at that point, I was looking for someone to help ease the pain, and the anesthesiologist was there. At that also experience, I understood the real importance of safe staffing because the nurses there really saved my life, and it wasn't enough of them. So with all taking this into respect, I think we really need to revisit what you and the governor are proposing in terms of having not so much trained nurses to perform the duties of anesthesiologists without the supervision. We got to think about that. We also got to think about opioid treatment as far as, again, trained, unsupervised members in the healthcare are providing prescription, especially when doctors themselves are not trying to be involved in that area. It's an epidemic, it's a crisis, and that issue, when it comes to opioid therapy, especially for chronic treatment, that typically is deferred to a pain specialist. So we got to look at all of this, and you being an anesthesiologist, I would have hoped that you saw the importance of quality care, how this can create a two-tier system, patients' rights, training, adequate training, the scourge of the opioid epidemic, and safety. We want our patients to be safe, and as my chairman had mentioned of the health committee, the patient's care is not purchasable. It's not negotiable. It's a human right. Thank you.
Thank you for your comments. The issue of chronic pain, I think, yes, as an anesthesiologist, I recognize the challenges here. There are individuals who come in who truly have chronic pain. They have a condition that may be causing the chronic pain, or they may have had an operation, and then as a result of that, they have a lot of chronic pain. And I do recognize there are specialists and subspecialists within anesthesiology who focus on this. We, in the department, and works closely with those in these specialties, and I have met with and spoken with anesthesiologists about this. When you mention the opioid crisis, and as I was saying before, one of the challenges we're facing is that we've gone from a situation where the use of some of these opioids in a therapeutic setting has now, particularly the fentanyl, and that's the real issue here in a lot of ways, and I will bring back some of these fentanyl analogs that the governor has gone after in a second. But the use of fentanyl has been something which has its benefits in the operating room and in the other healthcare settings, but it's now on the street, and it's something which is obviously causing many deaths. We work with our anesthesiology colleagues on how to make sure that those who have chronic pain can be managed appropriately. And I work with my anesthesia colleagues to talk to them about how can we address this opioid crisis, given their expertise as well. In December, I presented at the New York State Society of, the PGA, the New York State Society of Anesthesiologists, specifically about this, and I turned to my colleagues and asked, help us as the department to move forward and provide us with some ideas of what you think we could do, both as a government body, but also what they can do as clinicians to resolve this problem. So I'm happy to work with you and to work with those that are in the clinical setting to try to solve that problem.
So you do agree that CNRAs should be supervised?
So on that issue, that was the second part. And the first issue, so I've worked closely with many CRNAs in my career, in many hospitals, both in New York and elsewhere. What the proposal is to have them be able to practice within their scope of practice, but the proposal says that a qualified physician has to be provide the oversight in any of these Article 28 facilities, and as a physician who has worked with CRNAs, that is one of the things that you need to have there will be oversight by a physician, and that's what it's written.
Thank you, Dr. Zucker. Senate.
Our next speaker is Senator Gustavo Rivera.